I'm provided with axial slice CT scan, abdomen with contrast study, RT venous, and all are venous faces with also barium study. So I can see there is irregularity of the there is abdominal pelvic ascites is noted, and there is also irregularity of the liver margins are noted. However, liver is not enlarged, and there is a hypointense area, linear area is noted at the left lobe of liver, which is crossing from the anterior to the posterior wall, and spleen is normal, and the gut, the collection is compressing the gut and displacing it towards the medial side, middle, and there is no contrast extravasation is noted, and there is calcified area is noted in the lower abdomen, pelvic region, just anterior to the sigmoid. Could be a part of gut, but I cannot see a clear margins. However, the muscles and the abdominal muscles as well as the visualized bones are normal, and the left kidney is visualized, which is normal. As the collection is slightly dense, and the liver is irregular. My first I will first put, if the patient is a female patient, so it could be any metastatic ovarian collection with ascites, abdominal pelvic ascites, or as I can see, there is a hypointense linear area in the second image is noted. I will assure this in the sagittal or in the coronal images as well, and ask the patient about and ask the history of any.
It's male patient. It's male patient. So we will exclude. Patient. Yeah. Okay. So we'll exclude ovarian cancer. Okay. So if the patient has a history of trauma, so it could be a liver laceration with hemiperitoneum. Okay. So the irregular margins of liver, and however the liver parenchyma is not coarse. It could be a pseudo myxoma peritonei. Excellent.
But the scalloping is not. Excuse me. Sorry.
Differential diagnosis.
I cannot. My diagnosis is it could be any metastatic disease with collection, abdominal pelvic ascitic collection, and it could be any primary of.
Okay, this is blind and tubular structure. This is blind and tubular structure.
Yes, sir.
What do you think?
It could be appendix, ruptured appendix.
So the primary tumor, what do you think?
In the so, ma'am, it is any adenocarcinoma or carcinoid tumor of appendix, which is causing this collection, abdominal pelvic collection, and irregularity of the liver.
Yes. Okay. Agree? Yes.
And pseudo myxoperitonei.
Yes. Correct. I agree with your diagnosis, but I have a few comments. This is CT study with IV contrast and with oral contrast. So instead of saying barium, this is not a barium study. It is CT with IV and oral contrast. Okay. First of all, there is a large amount of ascites. So we have to comment about the amount of the ascites and the mass effect of the ascites. And already you mentioned this. So we have severe ascites, okay, and we have significant mass effect. You mentioned correctly the bowel loops are displaced in the center, and we have here deformity and scalloping appearance of the liver surface. All this because of the mass effect from the ascites. So that means we are dealing with thick fluid, mucinous fluid, that can cause this deformity and irregularity and scalloping of the liver surface. In addition, we have some subserosal deposits here around the liver. That means we are dealing with neoplastic process. Also, we have this thickening, omental thickening or omental caking. So all these findings, it means we are dealing with neoplastic process and metastasis in the peritoneum. And in particular, we are dealing with mucinous fluid because of the mass effect of the ascites. And mucinous fluid usually results from rupture of mucinous neoplasm. And this is pseudomyxoma peritoni rather than broadly stating there is peritoneal carcinomatosis. And also a close lock here in the pelvis, you can see a blind end tubular structure with possible foci here of calcifications. If we have pre-contrast images, it will be more clear. Blind ended structure, it means we are dealing with appendix. Normal diameter of the appendix is 6 millimeter. However, here it is significantly dilated, which means we are dealing with mucocele of the appendix. The presence of calcifications and the presence of background of pseudomyxoma peritoni raise possibility of mucinous tumor of the appendix, which is the most common cause of pseudomyxoma peritoni. Less commonly, as you said, it's okay. We can, other differential, it is ovarian, mucinous ovarian neoplasm, and less commonly mucinous tumor of the colon. So make sure that you evaluate the entire colon, no definite masses in the colon. So this is case of mucinous adenocarcinoma of the appendix with pseudomyxoma peritoni.
Okay, I am provided with CT scan axial sections, CT scan with contrast axial sections of the abdomen, and these are the arterial phase images. I can appreciate that there is a hyper enhancing rounded lesion is identified in the body of the pancreas, and however, no other such lesion is noted, and also in the liver, I cannot appreciate any enhancing lesions. So the pancreas appears normal in its shape and feathery appearance without any fat stranding. And no ascites is seen, liver is normal, rest of the viscera appear unremarkable. So based on these, based on the intense enhancing, arterially enhancing lesion of the pancreas, this is most likely a neuroendocrine tumor of the pancreas. And these, I would see further images of the liver to see if there are any hypervascular mats in other section of the liver, and would also correlate with the history of the patient if he has with the lab workup, if this is insulinoma or glucagonoma, and that's it. For further, we will reject it.
Your differential diagnosis?
Differential, the pancreatic tumors mostly are hypodense on arterial phase, and this can be a pseudo aneurysm, but it does not look like. So it is a neuroendocrine tumor.
Okay. First, I want to clarify the pancreatic protocol. Okay, we should do non-enhanced CT study. Non-enhanced CT study at the beginning, it's very important in detecting calcifications and fat or hemorrhage in tumor.
Okay.
Then we have to do late arterial phase or pancreatic phase, which is 35 to 40 seconds post-injection. And in this phase, we will see enhancement at portal vein. However, the hepatic veins will not enhance. Then we have to do hepatic phase or portovenous phase, which is 70 to 80 seconds post-injection. And in this phase, the hepatic veins and portal veins both will be opacified. Then if we have any liver metastasis, we can do delayed phase or delayed images, which is 3 or 10 minutes post-injection. And it's very important to mention early arterial phase scan, which is 15 to 20 seconds post-injection, doesn't add significant information on the staging of pancreatic tumor or pancreatic cancer, since there is no enough contrast in the pancreas. So, sorry, is my voice clear? Sorry?
Yes, your voice is clear.
So, pre-contrast to exclude any calcifications, fat component, or hemorrhage in the lesion. Late arterial phase or pancreatic phase, which is 40-second post-injection, and portovenous phase, which is 70 to 80-second post-injection, and delayed phase if we need delayed phase to assess hepatic metastasis. So now we have here hypervascular solid lesion in the pancreas. It's very important to mention, is it solid or cystic? Because we have two different differential diagnoses. So we are dealing with hypervascular solid pancreatic lesion. The differential diagnosis agree, neuroendocrine tumor, including gastrinoma, insulinoma, glucagonoma, or lipoma. Second differential diagnosis, as you mentioned, totally agree with you, vascular anomalies like pseudoaneurysm or varices or aneurysm. And it will be less likely here in this case. I will exclude it because you have to see direct communication with the adjacent vessels. In the provided images, I don't see a direct or frank communication with the adjacent vessels. Second, also another differential diagnosis, hypervascular metastasis from hypervascular primary tumor, especially renal cell carcinoma, and we don't see any renal lesion here, and melanoma, and sometimes breast cancer. So hypervascular metastasis from hypervascular primary tumor. Other differential, very rare entity, which is solid serous cyst adenoma. Serous cyst adenoma usually cystic, it is microcystic tumor. And however, there is rare entity called solid serous cyst adenoma. It can give also similar appearance to neuroendocrine tumor, however, it is very rare. Other important differential diagnosis is intrapancreatic splenule. Intrapancreatic splenule will follow the signal intensity or the pattern of enhancement of the pancreas. And intrapancreatic splenule, it's very important to diagnose this entity to avoid unnecessary surgery for the patient. And usually the next step we can do MRI. In MRI, the intrapancreatic splenule will follow the signal intensity of the spleen in all sequences. Any idea what else, what other examination that can confirm the intrapancreatic splenule? Any idea?
Sulfur colloid scan.
Excellent. Sulfur colloid scan. And also we have to exclude another lesion. This is part of the duodenum, second to third part of the duodenum. There is another tiny, small enhancing lesion here. Okay, any clue in this case to reach the final diagnosis? Sorry, in this image? Any clue in this image helping you to reach final diagnosis or to narrow your differential diagnosis? What about the stomach?
It has nodular mucosa. It is hyper enhancing.
Yes.
That means the patient is going on with the Zollinger-Ellison syndrome. So this is
excellent.
The gastrinoma.
Excellent. So we have hyper-enhancement at the mucosa of the stomach, and it means gastritis because, and this solid pancreatic lesion, gastrinoma most likely, and in gastrinoma we have high gastrin level, which leads to increased gastric acid and turns and diarrhea, gastritis, severe gastroesophageal reflux. So this combination of findings is compatible with Zollinger-Ellison syndrome, and usually gastrinoma located in the duodenum, most common, or pancreas, less common. Okay?
Ma'am, are the adrenals normal? Is there any lesion in the left adrenal gland?
Yes, it is incidentally probably adenoma. Incidentaloma, probably adenoma.
This is the contrast in CT exists at the level of bilateral femoral heads in the pelvic region, which shows that there are well-defined rounded hyper-enhancing lesion is noted with surrounding the serous, with surrounding the hyper-intense rim is seen at the level of inguinal region, and just medial to the common femoral artery and vein, and it is most likely inguinal hernia or rest of the visualized bones appears unremarkable. And
what's the content of this inguinal hernia? What's the content of the inguinal hernia? What's these enhancing structures?
Ma'am, these could be vessels.
Excellent, yes.
Or it could be through the spermatic cord is going, so it can be enhancing vessels.
Yes.
Causing the varicocele later on in the scrotal region. So I would like to see the scrotal sac to see if there is any varicoceles present to confirm the diagnosis, or in case of any pathology like carcinoma, which can lead to the compression. And I would also like to see the upper abdominal images.
What's your recommendation?
To see the full images, scrotal sac to see the testes, and upper abdomen to see the para-aortic lymphadenopathy, or in any case causing the compression of the left renal vein. Or
so do you think is it, so do you think is it primary varicocele or secondary varicocele?
Ma'am, I think it is secondary varicocele because it is unilateral, and it could be due to the secondary malignancy or obstruction at the upper level.
Excellent. This is second image. Same patient.
Okay, ma'am. This is the coronal image of the CT scan abdomen, which shows that there is a large heterogeneous signal intensity area. Enhancing mass lesion is noted just inferior to the liver, with well circumscribed margin causing compression on the IVC and vessels in the lower in the renal vein is also compressed, causing the secondary varicocele. And I cannot appreciate kidneys clearly as it is not provided in the image. So, so most likely it could be the heterogeneous mass in this area. It could be
the expected location of the right kidney. So the differential.
It is an adult patient, so most likely RCC.
Well done. So In this image, we have multiple enhancing grounded structure. It's enhancing similar to the adjacent femoral vessels. So we are dealing with multiple vessels in the inguinal region. In the inguinal region, we have bambiniform plexus surrounding the spermatic cord. So it is dilated. It means we are dealing with varicocele. Most varicoceles are primary and result from incompetent or congenitally absent valves in the testicular vein. And the left side, left testicle, is affected much more commonly, about 85% than the right. Any idea why? Why it's common on the left side?
Because gonadal vein drains into the left renal vein and then into the IVC, and on the right side it drains directly into the IVC.
Excellent. Because on the right side, shorter course of the right testicular vein, and its oblique insertion into the IVC, which creates less back pressure. That's why it's common on the left side. So we are dealing with unilateral right-sided varicocele, which is rare or less common. That's why we have to exclude any retroperitoneal malignancy. We have to exclude any compression on the renal vein or renal vein thrombosis or retroperitoneal malignancy or splenorenal shunting. This is image for the abdomen, selected coronal image for the abdomen, and we have heterogeneous enhancing mass in the expected location of the right kidney, causing mass effect on the IVC. We don't see right renal vein with multiple collaterals here. So this is case of renal cell carcinoma compressing and most likely involving renal vein with secondary varicocele.
These are CT scan axial images at the level of liver, IV contrast enhanced. Here I can see that there is it is in the portal venous phase. I can see that there is a hypodense lesion in the right lobe of liver that is peripherally shows peripheral enhancement, and few internal septations which are also showing enhancement, and few other nodular components as enhancing nodular components as well. There's also surrounding liver also shows some hypodense areas within it. These here I can see that there's fat strand. Some stranding is also noted adjacent to this lesion, and the lesion is laterally. It is abutting the wall, the lateral abdominal wall. Also,
differential diagnosis.
Differential diagnosis, ma'am. First, my diagnosis is of most likely this is an abscess. I will inquire about if there is history of pyrexia, and secondly, this can be a hydrated cyst as well because of the internal septations and the nodular components. I would also like to see the plain images if there are these are calcifications. And
final diagnosis.
Ma'am, final diagnosis is.
What about gallbladder?
Gallbladder. Okay, I'm looking at the gallbladder. Ma'am, I cannot see the gallbladder in these images.
Yes, but we have surgical clips here.
Yeah.
Right.
Okay,
so most likely we have.
Okay, this is post cholecystectomy.
Okay. So now, can you narrow your differential diagnosis? What do you think regarding these hyperdense foci, tiny hyperdense foci? Hello?
Ma'am, I got muted. Sorry. Ma'am, you were asking about the hyperdense foci in the vicinity of this, in the periphery of these lesions.
Yes, in the dependent parts.
Okay, ma'am. These can be the daughter cysts of the hydrated as well, but if there is
history of fever.
Okay. So, ma'am, I'm thinking about the abscess again. This is most like abscess.
Yes. Okay. We don't see gallbladder here. However, there is surgical clips at the gallbladder fossa, so most likely this is status post cholecystectomy. I agree with your description. It's rounded, enhancing. I don't see frank neural nodules or frank suspicious solid component within the lesion. It's enhancing almost smoothly, and there is surrounding edema here. This lesion is perihepatic with subcapsular extension. I agree, it is abutting or invading the abdominal wall. With history of fever, I will consider abscess. With history of cholecystectomy, these hyperdense foci most likely representing slipped calculi, and this explains the presence of liver abscess. This is most probably slipped calculi during surgery and result in liver abscess.
Okay. Okay, ma'am. Thank you. Ma'am, is there anything in the IVC as well?
No, it's just improper mixing of contrast. Time related to the timing of the scalp.
Okay.
Okay, I have. I can see four four cuts exit scan of the CT abdominal view at the level of abdominal pelvis at the level of the pelvis, most probably with zoomed image in the first three, and here I can appreciate that there is
okay.
Yes, ma'am.
Comment about the aorta and its major branches.
Yes, ma'am. Ma'am, I can appreciate there is hypointense rim at the surrounding the aorta with calcification in the wall, and it may be due to atherosclerosis. However, the lumen of the aorta is slightly irregular, with the superior mesenteric artery has with the slight irregularity at the origin of the superior mesenteric artery too, and narrowing of the superior mesenteric at its origin, and there is slight enhancement of the walls of the bowel.
What are the branches, the major branches of the aorta?
Ma'am, celiac artery, superior mesenteric, inferior mesenteric. Okay. And at this level, it is most probably then the upper region at the level of the start of the before the kidney. That is celiac, sorry.
Okay.
It is
it patent?
It is patent, but there is narrowing irregularity at the origin of the celiac artery.
Yes.
While mesenteric artery is normal.
Okay.
And atherosclerosis is also noted with irregular margin and calcification in the wall. And I can also appreciate that there is slight enhancement of the wall of the bowel.
What's inferior mesenteric artery?
If this is the third image is at the level of inferior mesenteric artery that I cannot appreciate the origin of the
This is the level, consider it, this is the level of the inferior mesenteric artery.
I cannot,
this one.
Yes, ma'am. I cannot appreciate the inferior mesenteric artery contrast in it, and there is it has no contrast in it and very thin and low attenuation, and its caliber is also very small, and this is probably due to any thrombus in the inferior mesenteric artery. That's why the walls of the bowel are also slight enhancement, giving the ischemic colitis. And
well done.
So my diagnosis would be ischemic colitis, secondary to the thrombus in the inferior mesenteric artery, and the lumen of the large bowel is also slightly dilated. However, there is no obstruction, and I can appreciate the all bowel loops normally.
Okay, well done. Okay, so you comment about the major branches of the aorta. Celiac, superior mesenteric arteries are patent. However, we have here thrombus at the inferior mesenteric artery. We don't see any contrast within the inferior mesenteric artery. And we have multiple calcified and non-calcified atheromatous plaques of the aorta and celiac trunk. The inferior mesenteric artery is supplying the splenic flexure of the large bowel, descending colon, up to the upper 2/3 of the rectum. So here this abnormality is at the level of the sigmoid colon.
Yes, ma'am.
We can see mucosal enhancement here.
Yes, ma'am.
And submucosal edema and enhancement of the muscularis propria. So we have here enhancement of the mucosa, enhancement of the muscularis, and in between there is submucosal edema, and this is target sign. Target sign, it means we have enhancement of the mucosa and muscularis propria with submucosal edema. The differential here include ischemia, especially we have thrombosis at the site of inferior mesenteric artery, which supplies the diseased bowel loop. Other differential also active inflammation, active inflammatory bowel disease or infection, or even target sign, still we can see it in case of portal hypertension. So in case of target sign, you have to exclude ischemia. It's very important to check the patency of the arterial and venous system. Arterial system, the major branches of the aorta, and venous system, portal and superior mesenteric vein. I want to comment about the protocol of bowel ischemia. It's very important to do pre-contrast images to exclude any hemorrhage in the wall of the bowel. Then we have to do early arterial phase or angio to evaluate the patency of the arterial system. Then portovenous phase to exclude any venous thrombosis, and avoid giving positive contrast, avoid giving gastrography. We have to give only water or negative contrast. So this is case of ischemia secondary to thrombosis of the inferior mesenteric artery. Any question?
Yes, ma'am, there's a question that can it be Takayasu's disease?
Sorry?
Can it be Takayasu's disease?
I'm sorry, really, I couldn't hear you again.
Madam, there is a question that can it be a Takayasu's, that is inflammatory disease of the vessels?
You mean distribution of the vessels?
No.
Distribution of
one question is that is the celiac artery fine?
Yes. Only mild. Oh, yes, it is patent. Vessels are patent, celiac and superior mesenteric. Only mild calcified and non-calcified atheromatous plaques, especially at celiac artery.
All right. And
aorta as well.
Want you to point out the SMA thrombus for them. Perfect.
This is the inferior. This is the last branch of the aorta, and it's usually very small. So you have to be very careful in evaluating inferior mesenteric artery. But here, you don't see any enhancement.
Right.